Welcome to another episode of the Airway Academy Podcast. I'm so excited about our guest today. Dr. Suraj Vatish and I have known each other for quite a few years. We met back at the Breathe Institute when I was just getting into my tongue-tie journey. And he is an oral surgeon in London, and he's really specializing in just doing these sort of releases.
Well, Stephanie, it's great to see you again. And yes, I have such good memories of us sitting next to each other on the Breathe course, dissecting everything that we were getting. And yeah, honestly, so good to see you again after all these years. And you haven't aged one bit. So how I got into airway dentistry actually turned into, there were so many different factors. Now, number one, I've always been very holistic in my view of seeing patients. And I always found that coming as an implant surgeon, you were very flawed. You're only doing one thing. You're looking at bone, you're looking at screws, you're looking at cutting, etc. And although I enjoyed doing it, I didn't find any job satisfaction. Then I did a bit of periodontal work. I did a certification in periodontics, and I found, wow, that actually, the gums can tell you a full story about the body. Then my business partner told me about tongue-tie releases, and I was like, well, I've done a few of these in Spain, quite a few. I never enjoyed it because it was with scissors, it bled a lot. And she said, look, don't do Dr. Baxter's course, go to the Breathe course, and if you don't like it after all this, you don't need to do it. And I was like, okay, fine. I've always had my mind open. And then after doing Dr. Baxter's course, my mind was blown, because I couldn't believe that this little string under your tongue can affect so many different things in your body. And it brought out a side of me that actually I love to work in a team. I got to start working with osteopaths, chiropractors, lactation consultants. And then after I did the Breathe course, I got introduced to the world of myofunctional therapy. You got to see how patients' lives were changing, which if you go from kind of doing implants, the nicest thing you get is, oh, great, thanks, doctor, I've got a tooth I can chew again. To see a family struggling with feeding issues, with speech issues, and then to see a child who's not speaking, and then you treat them, and all of a sudden the parents are coming to you in tears because that child is now saying new words all of a sudden after you do a tongue-tie release. It's so gratifying and actually feels like you're making a difference to people.
I agree. It's been so rewarding being in the airway space. I know that you really have concentrated on oral surgery aspects, but a lot of people who are listening are general dentists that maybe aren't that interested in actually learning the surgical aspect, but we really didn't even get trained in how to identify most types of tongue ties, right? Like we kind of learned in dental school, like the very severe tongue ties, ones that actually affected speech. And other than that, we didn't really learn how to identify them. So, what would you tell a general dentist who's like, hey, I don't know if I want to actually do the surgeries. How do you think that they should go ahead and start learning when to even refer?
Very good question there. Now, identifying and looking at what doctors argue either fair as 6 or getting a very good base work in how to kind of see dysfunction in the patient. And it's very easy. You don't need to do tongue ties just to do the surgeries. Let's put it this way. So just by identifying and seeing the dysfunction in a patient, you can make a big difference in that person's life. Because a lot of the time, this person's kind of just, as we say, going through the gears in life. They are probably not sleeping too well, but they're getting up in the morning, they're kind of carrying on, they're probably very tired, they're probably going through a lot of back and neck ache, and most of the time they'll see their dentist because they're grinding their teeth a lot. Now, for the restorative dentists out there, and I'll tell you this from personal experience, we've all had that patient who will grind through everything you give them. You give them a new mouth guard, that's gone in 2 seconds. In my case, I would do some lovely implant crowns, and those implant crowns are loose, falling off. And then my biggest nightmare, because I'm scratching my head thinking, what have I done that's wrong? And this is when I found from an airway standpoint that this was actually a tongue tie. There was some some airway restriction, some sleep issues as well. So many different things compounding to the fact that I was seeing this patient for repair dental work. And what I tell a lot of my dental colleagues, I said, in the end, our duty is to be holistic and give a good service to our patients. Now, unfortunately, in the UK, we have the National Health System, so it's kind of very tooth-based dentistry. So you come in, you look at decay, you look at the patient's brushing their teeth, okay, thank you, next. But in the States, you have that culture of giving back to your patient, so doing a full assessment. And a lot of the times in dental school, we're told if it's an anterior tie, that's the only time it exists. But it's a very quick test. And I tell all my patients, even when I've got an implant patient coming in, I say, open your mouth really wide and lift your tongue up. And then I can see, okay, is that patient tied or not? Because in the end, if there is a tongue tie there, I know that patient's probably bruxing, we've got some sleep issues, and I know that that might affect the longevity of my implant and the implant restoration. So it will always, excuse the pun, tie back into what you're doing. And so that's what I tell everyone. I said, yeah, I was like, just look at the bigger picture. Look at your patients as a whole. Start off with, okay, looking at how they're breathing, how they're walking in the room, and then your dentistry will improve as a result of that as well.
So I think educating patients that have never heard anything about a tongue tie is a really hard aspect. Earlier in your career in this, how did you help to educate each patient when they didn't know they had a problem when they first arrived? They thought, oh, I'm just a grinder because I'm stressed, because I hear that all the time.
I know, me too. And a lot of the time it's because they've not been told otherwise. And I think a lot of people in the UK will kind of go for an issue and they'll be told, oh, it's stress, take care of it. Now, from personal experience, I've seen some patients with digestive issues who've had cameras in their stomachs. They've had it, and the gastrointestinal doctor said there's nothing wrong there. You're just stressed. The patient's gone to me, I'm not stressed, there's something going on. And they've come to me and we found out actually it's aerophagia, because the tongue's not moving too well. The patient's been swallowing air, and that's been triggering their IBS. And surprise, surprise, after doing the myofunctional therapy, doing the release, this patient now is their life has been changed. Now, I do have the other end of the spectrum. When I first started, I was getting implant patients and I'll be asking about teeth grinding and sleep, and they'll go, why is sleep concerning to you? I said, well, because it makes a lot of an impact on how you are as a person. They go, oh, but my dentist never asked me how I sleep. And then I'm coming in and telling them, oh, wait, actually, your tongue's not moving too well. And they go, well, how's that going to affect me? And I said, well, the simplest analogy I give everyone is, imagine if I tie your feet together with a shoelace and I get you to walk around. So a bit of this is Dr. Baxter's analogy. I said, you'll get some people who'll be able to walk, run marathons. Like, I know, Stephanie, you love surfing. They'll be able to do everything with that string tied around their feet. Then you'll probably get me, who probably won't even be able to walk out the door, do everything. And it each depends on how someone can kind of compensate with that string. Now, we all know that that string will make, in the compensating cases, will mean that you'll have to use a lot more energy. Your energy comes at a cost. So this energy in the young children could be used for growth, could be used for development, but instead it's being used to kind of keep the mobility. And that's where I'll tell people is, you'll get through everything, but at some point the compensations will come to an end. And when you explain to patients in a very simple way the importance of the tongue muscle as well, because let's put it this way, we talk about our feet being tied up. No one's going to hesitate twice to go and see a surgeon to get their feet ties removed. Or if you've got webbed hands, they won't even think twice. They're not going to be like, oh, we'll wait and see. They're like, no, get rid of it. And we use our tongues for so much more. We use our tongues for sleeping, breathing, and eating. So I tell patients, if you look at the importance, why would you not get a tongue tie assessed and treated or even managed? But if you have webbed fingers, you'll be like straight away, yeah, let's get it fixed. And then some patients like, that actually makes a lot of sense. Now, hopefully it makes sense to you and your listeners, but I like to keep things very, very simple. And I think that we all need to be aware of risks, benefits, but I don't know why there's so much animosity when it comes to a tongue tie release. But if someone's got webbed fingers, you're like straight away, yep, let's get it fixed.
That's so true. And I love that analogy. I'm definitely going to steal that for my practice for sure. Yeah. And so you do a lot of education and stuff too, right? So you've got a course coming up this fall, right? Tell me about that.
So on the 16th to 17th of October, I have a lot of colleagues coming over from the States, and thank you for coming as well now. But what the aim of the course is to talk about tongue ties and their effects on the body. Now, what we aim to do is bring everyone from each specialty over. So we have lactation and feeding consultants, we have pediatricians, we have an ENT sleep surgeon, we have myofunctional therapists, and we're even going to target the treatment on different aspects. So a lot of the time, obviously, I talk about laser releases, but I'm also bringing one of my colleagues who does scissor releases really well as well. Now, the idea is to take the average dentist, lactation consultant, sleep consultant, anyone who's got an interest in how the tongue tie can affect the organism, and see the progression from infancy to childhood to teenagers to adults, and then give you a full spectrum of how you can understand the tongue tie. Now, we're not talking about treatment too much, but it will be mentioned, but it's mainly about identifying, finding your tribe and working together for the health of your patients.
Yeah, I love that. And I'm so excited to be a part of it. And so if you are a general dentist that is just kind of getting into this, would you say learning the orthodontic aspect for expansion, or like learning just how to identify tongue ties and even just knowing when there is somebody to refer would be like the beginning stage for you? What would you recommend?
Wow, very controversial question in my practice there, Stephanie, because the orthodontist is always like, you should see expansion first, and I'm like, you should see tongue tie first. Now, there's no right or wrong answer. I think they both, honestly, they go in harmony. You should be able to identify the crowding, the lack of tongue space, the ortho issues, but you should also be kind of looking at what could be causing them. So what I would say to patients is, obviously, they're both, when you look at dysfunction and you do like the Airway Academy course, which is a very holistic course in the orthodontics, and you're including the tongue tie diagnosis, you will have all the tools to see everything. Now, there isn't one which kind of outshines the other, but I would say the easier one to spot is probably the more orthodontic side of it.
Yeah, I would definitely agree. That's the easier side. As a dentist, we're kind of trained already to spot the malocclusion, but then learning the cause of that malocclusion sometimes can be definitely a little bit more tricky. And, you know, it's one of those things where the more you see it, the more you start talking about it, the more you start looking for it. Now you see it everywhere, right?
Oh, tell me about it.
Like, do you go to the airport and see all of them? Like, you walk around and you're like, airway issue, you're tongue tied. Like, you speak to the gate agent and you're like, you're tongue tied. God, you need me. But I can't have that conversation right now. Just give me my ticket. Thank you. Check my bag. But I know that's how I feel everywhere I go. I see it. I can't unsee it now.
Oh, I was watching Walking Dead the other day, and there was a guy screaming at the top of his head, but his tongue was so tied down. And I'm like, look, there's a tongue tie. And you're right. Once you see this whole world of dysfunction and like airway issues, especially like in I think Stranger Things got really popular, and all the kids are like, you mouth breather. And I'm like, good, you're raising awareness about dysfunction, but you see it everywhere. Like, it's hard not to see. Like, when you first become a dentist, you look at teeth. Then you become an implant dentist, you look at gaps. And then third, when you become a tongue tie airway dentist, you look at everything else. You're like, that posture's off, that bites forward, and you start to see so many different things and you can't unsee them. I think that's the tricky part.
Yeah. I have a question for you. So obviously it's best to identify this when we have infants, right? When there's, feeding issues and things, like right off the bat, first couple weeks of life, the earlier the better. Is there like an age space where you like to say, okay, let's not treat right here? Or what is your range that you feel comfortable? Or is there an age grade that you don't treat?
That's a very good question, because I get that all the time. And for me, it's very symptom dependent and how strong the child is, let's put it this way. Because when you get over about 2 years old, you get more teeth involved in treating the patient. So you have to take that into consideration when doing the aftercare. You get children who have compensated now for 2 years rather than having a baby who's been compensated for a few weeks/months. And the treatment becomes a lot harder in terms of the surgical procedure, yes, can be managed in some cases with use of papoose board, or even sometimes in some cases light intravenous sedation. Obviously, in the UK, we don't have intravenous sedation, so we have to use restraint methods. And it's not the most pleasant thing. Yeah. I know it's my colleague. The only person who does it is Dr. Roche in Ireland, and he's a pediatrician, so he manages to do sedation at that age. But we have to kind of weigh up the pros and cons of treating, let's say, between the 2 to 3.5-year-olds. In our practice, we find that there are some 3-year-olds who walk in the door, and you can have a full conversation with them. They can sit still. You can work with nitrous oxide, and you get a great release with doing myofunctional therapy and the functional frenuloplasty approach. The youngest we've ever had was a 2.5-year-old, and honestly, like, she sat still I still remember to this day because I've not had it. She let me numb her. She let me use a laser. She let me suture. And she was too busy watching Bluey Teeth and Care. And she saw my myofunctional therapist afterwards and did the exercises. But do I get patients like that all day? I wish I did, but no. Usually the case, I would say to you, like in your practice, you've got it right. I would say easy times about a year, 18 months. That's probably the first time. And then we get that gray area to us, which starts at about 18 months to 3 years old. And then it's very compromised at that time. Then I would usually, depending on the child, if we have a lot of speech or growth issues, then look, the benefits outweigh the risks of surgery. If we don't, then I would say, look, periodically try myofunctional therapy if possible, try myomunchies, try other devices to manage the time, or even see an osteopath, the chiropractor, to help with strain patterns, and then come and see us when you're about 3-ish years old.
Yeah, I love that. And you mentioned myomunchie. So I use both myobrace and myomunchie in my practice for different things, but was wondering, so do you start most of your patients with a myomunchie in addition to their myofunctional therapy, or how do you feel about that?
Myomunchie is a great device to help people chew because, as we know, as a society, we don't chew as much. And our foods have become very soft, and myomunchie is a great, easy device for us to start using. Yes, when we do get the kind of 3-4-year-olds, my myofunctional therapist is using myomunchie as a standard protocol, and also myobrace afterwards when we start seeing the kind of and using myobrace when we start seeing the orthodontic crowding coming up. Both of them work in conjunction. They both have very similar philosophies. I love the myomunchie as a kind of entry-level device because it's not really generated for orthodontic change. It's just helped to chew and help develop it's just made for chewing, and it helps with development. That's how I see it.
I think there's a lot to be said. Online they call it like face yoga and all this sort of stuff of like, how to age better. But I think there's a lot to be said about that because it actually is, it's myofunctional therapy is really what they're trying to do with some of this face yoga online to help with anti-aging. And the myomunchie is kind of an easy at home 10 minutes, or, I think they say 5 to 10 minutes a day for adults. And that's what the founder of it, that's what he was doing. It's like 5 to 10 minutes a day before bed. And, he lived to be 91 years old. So, hey, he obviously did something right?
Exactly. It's a great tool.
Well, I am so excited about all the collaboration that we have coming up this fall. Is there anything else that you wanted to chat about before we wrap it?
I think, it's been a great conversation we've had. It's really nice to obviously connect again. And it's so good to see how starting at the same place, both our worlds have kind of diverted at the end, come back. And it's really good to be working with you and the team. And honestly, I'm so honored to have you come over to us and to be part of Airway Academy as well. So thank you for everything, Stephanie.
Well, we can't wait. Thanks again so much for being on the podcast. If you enjoyed this, don't forget to like and follow us. We're on YouTube, Instagram, and all the places where you can find the podcast.